Oh, recording in progress. It's official. Hi, everyone. I'm Molly, and I am the lead stroke educator, program educator here at Essentia Health in Fargo. And I want to thank Carly for reaching out. I'm a little nervous. This is the first time I've talked in front of a group like this, so I'm normally very social. So I'll get the bugs out here as we progress. But today we're just going to talk about some advanced stroke care and some of the services we offer here at Essentia. So, do I just click? Does it just go through? Oh, there it goes right there. Beautiful. So this is what we're going to be talking about today. So again, providing an overview of the Essentia Health Comprehensive Stroke Care Program, identifying treatment options for stroke patients at Essentia, and then just doing a quick review regarding IV alteplase administration and monitoring, and reviewing our NIH. So disclosures, no conflicts of interest. I'm just here to provide education. No commercial support was received, and disclosure to participants prior to presentation of off-labeled uses, and which I do not have any. So this is a video I found, and in part of my education role coming up in the next year is I'm going to be going out to our rural communities. We're going to start doing that again now that COVID's hopefully getting better, knock on wood. Going out into our rural communities and providing some education for patients. And so in developing that presentation, I found this really good video, and I think it would be good to share it today. It's only about a 1.5-minute video. So it's called Stroke Through Their Eyes. So in watching this video, I just want to pose the question, would you know if you were having a stroke? Watch how a stroke unfolds through the eyes of someone who is experiencing one. I will tell you, it's a little bit of a heart, it hits your heart a little bit, this video. So
now he's been wanting to put garlic chives in everything.
Not everything.
Dad, the side of your face is drooping.
Oh, we're just not seeing
Probably
it. We're
nothing.
hearing it.
Are you okay?
I'm not seeing it anyways.
you're not seeing or hearing it?
I'm hearing it, but I'm not seeing it. Nikki, are you seeing it or are you just hearing?
Just hearing it. Yep.
Yeah.
You can't see it. So you might have to
Let's see
share
here.
differently. Is that how?
Sometimes you have to just reshare. Let me
Okay.
see here. So try just resharing and seeing
All
that
right.
helps with the video.
Let's see.
There it is. Yep. So if you want to just go back to the beginning.
There you
There we
go.
go. Now we're seeing it.
Oh, but I wonder if I shared audio though. Just 1 second. Let me try that one more time. Oh, yep. Share sound is clicked. Okay.
Perfect.
This again, guys. Here we go.
Now he's been wanting to put garlic chives in everything.
Not everything.
Dad, the side of your face is drooping. Mom?
It's probably nothing.
Dad, are you okay?
You're slurring. Why are you slurring? Raise your arms up in the air for me.
Dad, are you okay?
Gracie, call 911.
I can't see.
Dad!
Tim.
I need an ambulance to 7th floor Avenue.
Tim, look at me, Gracie. Tell them to hurry. Tim, look at me, Tim. I don't know. I think he's having a stroke. Sweetheart. Mom, they're here. My husband. I think he's cold. Are you cold, honey? Are you cold? Okay. Gracie. See, Gracie's gonna come, sweetheart. We're just gonna go in the ambulance right now. We're gonna go to the hospital. Okay? Huh? I'm right here. Gracie, meet us there. I'm right here. Okay, here we go. You just stay right here. You just stay and breathe. Just breathe. Tim.
Dad?
How you feeling?
I'm fine.
Well, you've had a stroke. But because you got here quickly, you're looking at a full recovery.
So does anyone want to share their thoughts on that video really quickly?
That was hard to watch. That was powerful. That was good. I like that. Yeah, I don't know. I was thinking of a time I was at it was like a job eval thing with back when I taught in the public schools, and I was talking to the vice principal, and my speech got weird all of a sudden. It was like the lights were bothering me. And and I remember her saying to me, and I just said, I feel funny. And she said to me, well, I hope you're not stroking out on me. And we kind of laughed about it at the time, but it's not funny. And it's so serious. And we should have probably gone through all the steps. I mean, I think I don't know what happened. That was years ago, and I'm fine. But it was just, yeah, I think just the more we keep talking about fast and about those things, the more people will, because, you know, when you're in the heat of the moment like that too, cooking dinner, you know, you're not expecting that to happen. So I think that's a great example of how fast we need to act. And
and I think too, with this video, it does show, like, you know, obviously as the family members, the wife and the daughter, you can see how the fear in them, you know, saying, well, what's going on, Dad? And then just taking it from the perspective of the patient who's actually having a stroke, and imagining the fear that they're going through, knowing that there's something wrong, but they either can't communicate it, they can't tell you what's going on. So yeah, it's one of those videos that you're like, holy crap, like, wow, that would be extremely scary. So any other comments at all? Okay. So again, we're going to talk a little bit about what makes a comprehensive stroke center. So
Molly, if you're going to go back to your slides, you got to reshare again.
Reshare again.
We're still seeing YouTube.
No, I don't want you to see YouTube anymore.
I know. I don't know certain computers or what the deal is, but, and then you want to go into that display setting one, just to go back to presentation mode. I was seeing your notes again, like we had. Okay. You did practice before, Molly, and
I know.
Okay, you're all right.
Okay, so this one.
Okay, and then slideshow. Yep.
From
beginning, or no, not. You can do from current slide.
From current slide. Okay.
There you go.
And then I got to go up here and swap. There we go. Now we're in business.
Yes, perfect.
So again, what is a comprehensive stroke center? So again, we're happy that Essentia is a comprehensive stroke center here in North Dakota. And comprehensive stroke centers are hospitals that meet standards to treat the most complex stroke cases. So a comprehensive stroke center has these things available. The biggest thing is that 24/7 availability of personnel, imaging, operating rooms, and endovascular facilities. So again, if somebody is coming in with a ischemic stroke and they've got a blockage and they need to get in and get it, have an endovascular treatment for that, we have availability of that. If somebody comes in and is having a hemorrhagic stroke and they need to go in and do any type of aneurysm coiling, aneurysm clipping, or even a craniotomy, we have that availability here as well. The other big important thing to remember when you're taking care of those most complex stroke cases is those patients need to be under extremely close ICU monitoring and ICU capable facilities, which is what's kind of sets that comprehensive stroke center apart. Okay. So this is our Essentia Health interventional neurology team. We do have 3 interventional neurologists that actually come to us from Kern Institute in California, Dr. Dan Namoudi, Dr. Thomas, and Dr. Vijay Appa. And along with our interventional neurologists, we also have 2 certified nurse practitioners, Megan Carlblum and Michelle Kilber. And they are both wonderful. And then in addition to our interventional neurology team who can do thrombectomies on patients, also do cerebral, any type of cerebral study on the patients. We also have a phenomenal neurosurgeon here at Essentia. I'm sure maybe some of you have heard of Dr. Mickey Sirkin. We also have, what's the word? Other doctors that come for times, and what's the word? Locums. They're my coworkers helping me out there. We also have a couple of great locums that come and do neurosurgery here. So again, these are the doctors that do Dr. Sturkin does aneurysm clipping. He also does our craniotomies as well. So, and then his team of NPs. Any questions so far? Okay, so if a patient was to have a stroke, and since you guys are based out of Grand Forks, some of you, if somebody was to present to Altru and they decided, they talked to, let's say, Dr. Dan Moody here at Essentia and said, yep, I think we need to send this patient down to you guys for further treatments, whether it's a thrombectomy or whatever it may be. What can those patients expect once they arrive here? And again, this all adds to that comprehensive stroke center, which is what we have here at Essentia. So again, that neuro critical care unit, okay, 24/7 follow-up with trained neurointensivists. We have 10 designated beds actually up in our ICU that are for neurocritical care patients. And then we also have a core stroke team, our nursing staff throughout the hospital, on whether it's our neural floor, whether it's the ICU, there's actually core stroke team members, registered nurses that take care of these stroke care patients, okay? What's nice here at Essentia is we also do an interdisciplinary team approach, which I think is really important for our patients, especially if these patients have been used to being at home, no problems before, and then all of a sudden they have a massive stroke, and obviously life has changed for them, and they're going to require maybe an extensive rehab after they get discharged, or they may need to go to a long-term care facility. We have a great team of case managers here that help with that process. Our patients, once they have been diagnosed with a stroke, they do see speech therapy, PT, and OT while they're in the hospital. And then obviously a lot of times that's continued on in their next stage as well. And then of course, we also have our dietitians that educate these patients, especially if they're at risk, high risk factors for, high fats, high salt diets. Stroke program educator, that's me. I go around and educate the patients when they're to a point where they can understand kind of what has happened to them, where they can identify their risk factors, and then kind of looking forward. One part of being a stroke educator is I like it when families here with the patient, because again, talking to just the patient who has already had this type of brain injury related to their stroke, they're not going to retain a lot of that. I always kind of wait till the end of their time in the hospital when family is available, because then there's multiple people that can listen to what we have to say. So we also have the two people I work closely with. Lance Harris is our program coordinator, and then Trisha Lorenzen is our data guru. She is phenomenal with the guidelines. Again, we are a nationally accredited center here. The other thing that patients can expect when they go to a comprehensive stroke center is the follow-up in the stroke clinic. And then I know Altru has this, but we also at Essentia have a wonderful thing that I think is very good for stroke patient survivors and their families, is that monthly stroke support group. Okay. So just a quick review about the different types of strokes that we see. So again, our ischemic stroke occurs when a vessel supplying blood to the brain is obstructed, okay? This is actually the most common type of stroke that we see. 87% of all strokes are ischemic strokes. The hemorrhagic stroke occurs when there's a weakened blood vessel in the brain that ruptures, and blood starts to leak onto the brain tissue. And blood is actually toxic to our brain. So hemorrhagic strokes account for about 13% of all strokes. These strokes are a little bit more serious, and we'll talk a little bit about that here in a little bit. And then we also now classify transient ischemic attacks. They used to be called mini strokes, but we have learned that there is actually no small stroke. They're compared to small or large stroke. A stroke is a stroke, and it has impacts on our brain. So again, a TIA we now call a warning stroke. And this occurs when there's a temporary blockage of blood flow to the brain. The big thing with our TIAs is patients start to have weakness, maybe a little bit of blurred vision, slurred speech, and then maybe 20 minutes later, it's all better. So they're like, oh, I must have just slept wrong on my arm, or oh, maybe I just have a headache from lack of caffeine or something like that. It'll be fine. I'm just going to ignore it. And that is not the best thing to do because a lot of times when a patient has a TIA, 20% of these patients can develop a full-blown stroke within 2 months. So any questions so far? Okay.
Maybe
So again,
maybe you're gonna get into this, but okay, so let's say that video. Would he have been given, like, it's TPA, right? Have you,
yep.
would they have given that, like, when does that happen? Does that happen right when they get to the hospital, or like in the ambulance, or?
Yep, and I am going to talk about that.
Okay,
That's a great question.
So you keep doing, and we'll.
Great question, yes. So again, when we look at our ischemic strokes, those most common types of strokes occurs again when a blood vessel that supplies the brain with oxygen becomes blocked or clogged, okay? So with our ischemic strokes, we have either a thrombotic or an embolic stroke, okay? So a thrombotic is caused by a thrombus or a blood clot that develops in the arteries supplying blood to the brain, okay? This type of stroke is usually seen in older persons, especially with our patients who have high levels of cholesterol or atherosclerosis. So when I go up and educate patients, I don't know if you can see my fingers, but when we think about when we're nice and young, okay, our blood vessels are nice and open like this. So blood flow likes to go nice and easily through our blood vessels, okay? But as we get older, we get plaque buildup on the inside of our arteries and vessels. So as we get older, that diameter of our vessels gets smaller and smaller. So can blood get through there as easy? No, because of that plaque buildup along the artery walls. And when that happens, obviously, when we have a decrease of blood flow in our arteries, it causes a decrease of blood flow to our brain. Ultimately, decreased blood flow causes decreased oxygenation to the brain, okay? And then we also have, along that same line of ischemic stroke, we have what's called an embolic stroke, okay? And this is seen in patients maybe who have recently had heart surgery, maybe have recently had some type of orthopedic surgery, and they're at risk for developing a DVT. So an embolic stroke, again, is caused by a blood clot that forms somewhere else in the body, whether it's the heart, whether it's our legs, wherever it may be, and it travels through the bloodstream and goes up into the brain and blocks the blood flow and oxygen to that area of the brain. Okay. So this is a very interesting thing. I actually didn't know about this until I started this position, is this very interesting. This is what our interventional neurologists really pay attention to, is what's called the ischemic penumbra. Okay, so ischemic tissue potentially destined for infarction, but not yet irreversible injured. So if you look at this picture here, this little yellow piece here, this is the clot, okay? This is our big blood vessel, and here's the clot that's blocking blood flow and oxygenation to this area of the brain, okay? And because of this, this is the infarction, okay? This is a, pretty good size infarction. So this is where the stroke is happening. But we can see that this stroke has not been completed, meaning that the stroke is still happening. But what we can do is, if the intervention neurologists see this and they see that there's a little clot right here, and we're going to talk about this, they can go in and do what's called a thrombectomy and get this clot out of the way. So this whole area right here is called an ischemic penumbra. And eventually, if we don't get this clot out of the way and start getting reperfusion, this whole area is going to be infarcted. So again, all this nice tissue is right now, it's lacking some oxygen and blood flow, but it's not dead yet. But if we don't get this figured out pretty quickly, this huge area is going to become an infarction. So if you think about it, again, not a small stroke, but an area of smaller infarction versus a huge area of infarction. Does that make sense? Okay. So just like Carly had mentioned, what do we do then? Ischemic stroke treatment. So the biggest thing, and I'm sure you guys have maybe heard about this, is when somebody like that gentleman in the video, all of a sudden he drops his phone, he's got the facial droop, he's got the slurred speech. That is what is known as when his stroke symptoms have started. Okay. And also that is known as your last known well, because he's around people. His wife and daughter can say, okay, Dad, we're making dinner at 6 o'clock here, and all of a sudden you're having these symptoms, and it's witnessed. So that's the last known well. So from the last known well time, up until 4.5 hours later, patients can qualify to get this TPA, okay, this clot busting medication, okay. This is we don't necessarily do this, but there are cases where within 6 hours of symptom onset, they can get some TPA in specific cases, but most of the time, this is where we sit here at Essentia, is last known well up to 4.5 hours, okay? Also, we want to, again, if we look back at that ischemic penumbra and we think, okay, 6 hours, we've done the imaging, we can see that there's a big clot in the middle cerebral artery, we need to get in and get that clot out of there. We have up till 24 hours to do the endovascular retrieval. Okay, so again, patient maybe is, again, like in that video, they were preparing dinner at 6 p.m. And then they have technically until 6 p.m. the following night to get in and have that done. But again, the sooner we can get that treatment done, we're going to save more brain tissue. Okay. Any questions on that? Okay, and we're going to talk a little bit more about alteplase here in just a little bit. Okay, so now looking at the other side, so the hemorrhagic strokes. So again, a hemorrhagic stroke occurs when a blood vessel that supplies the brain ruptures and bleeds. Okay, when an artery bleeds into the brain cells and tissue do not get the oxygen and nutrients they need. And again, that pressure builds up in our brain because of the irritation. Again, our brain tissue does not like blood on it. It's toxic to the brain. And so when that happens, the inflammation process starts and our brains start to swell. Okay. So again, these are not the best type of stroke for people to have. These are a little bit more tricky. So hemorrhagic strokes, again, are divided into two different categories. So we have our ICHs, or our intracerebral hemorrhages, and then we have our subarachnoid hemorrhages. So our intracerebral hemorrhages is when bleeding is from the blood vessel within the brain, okay? Bleeding occurs suddenly and rapidly, okay? This can happen due to trauma, or sometimes it can be just spontaneous. And most of the time with our spontaneous ones, we link them to uncontrolled high blood pressure, smoking, and drug use, okay? Difference between that and a subarachnoid hemorrhage is when there's results when bleeding occurs between the brain and the membrane that covers the brain, so the meninges. This is a bad one. This is not the type of stroke you want your patients to have. These are very not a good survival rate with our subarachnoids, okay? So here's a perfect example of what we're looking at when we see an ICH, okay? So you think about our brain, we've got lots of arteries and vessels all over in our brain, okay? So here's a little artery that is now ruptured, whether it's because of an uncontrolled blood pressure, whether it's because of somebody has done some type of drug that's went to our brain, that weakened blood vessel all of a sudden bursts. And when that blood vessel bursts, there's blood that leaks into our brain tissue, okay? And then this is the subarachnoid hemorrhage, okay? Again, these are most likely caused by an aneurysm, okay? And as we can see, our blood vessel here has a big old aneurysm on it, okay? And aneurysms are kind of like a balloon where they can only take so much stretching and pressure before eventually that aneurysm ruptures. And when that aneurysm ruptures, again, blood leaks into the brain. But because of the area where the subarachnoid is, as you can see, it quickly puts pressure on the brain and also on the skull. And that's why these are so dangerous, and so they have such a high mortality rate. Okay. And again, that's what this graph shows, is the high rates of death and disability when we see with our cerebral aneurysm rupture, okay? As you can see, 40 to 50% people who have a cerebral aneurysm that's ruptured, 40 to 50% of patients die, okay? 20 to 35% develop moderate to severe brain injury, okay? And then 15 to 30% minimal brain damage, okay? So, but what does that mean? Does that mean, okay, somebody's having a hemorrhagic stroke, they're probably just not going to survive? Not necessarily, okay? We have different treatments for a hemorrhagic stroke. So we have our medical intervention, okay? And that's obviously if somebody is on some type of blood thinner, Coumadin, Brilinta, any of those medications, maybe they have a history of AFib, maybe they've recently had some type of surgery where they need to be on some type of blood thinner for a short amount of time. Okay, we need to reverse that anticoagulation. Okay, so vitamin K. And then we also want to reduce our blood pressure. We do not want our blood pressure to be 200 over 100 if somebody is actively bleeding in their brain. Okay. The other thing, which is again what makes a comprehensive stroke center, is the ability for either the interventional neurologist or our neurosurgeons to be able to do craniotomies and clot evacuations, aneurysm clipping, and also our external ventricular drains. Okay. In addition, also aneurysm coiling, flow diverter placement, and vascular abnormality glue embolization. That is a long word. Any questions so far? All right, and then this is the one I like to talk about the most because you guys maybe have all known somebody who's had a TIA, or maybe you've known somebody who's had a stroke, or maybe somebody will be talking to you and saying like, oh, 2 weeks ago, this is what happened to me. And you're thinking, that's not good. Okay, they maybe had a TIA and didn't go on and get treatment. So again, our transient ischemic attacks, or our TIAs, are now, we call them warning strokes. Okay. Again, TIA, temporary cell death, and attack is sudden. Okay. That's why it mimics so much like a stroke, but then all of a sudden the symptoms go away. Symptoms can go away within a couple minutes of it, can go away within an hour, can go away within 6 to 12 hours, whatever it may be. So a lot of times people think, oh, I'm fine, I don't need to go in. Okay. But again, about 1 in 3 people who have a TIA will eventually have a stroke. And again, whether it's a stroke that doesn't cause a lot of disability or a massive stroke that changes their life forever. Okay. So part of our comprehensive stroke center here at Essentia, and actually any type of comprehensive stroke center, is we do what's called a stroke alert system. Okay. Meaning, and this is all based again on that last known well, which we talked about a little bit ago. Okay, so when we get a call, let's say from our outside rural community, so let's say what's the place between here and Grand Forks, let's say somebody from Hillsborough, we get a call from EMS in Hillsborough saying, we have this 68-year-old patient, was at home this morning, and while eating his breakfast, all of a sudden he dropped his spoon. He had complete weakness on the left side. His wife noticed facial droop. He started talking weird. He couldn't really see. Okay. We always wanted, when we think of last known well, we don't want to say, oh, about 30 minutes ago, or oh, about 45 minutes ago. No, we want an exact time. So this morning, so what is the day today? 15th. So 12:15 at 8:35 a.m. because that will give us the exact time that our patient was last known well. Okay, because then from that time till about 4.5 hours later, that patient would technically be considered a level 1, meaning that they would be, if they meet the requirements, they would be able to get alteplase, or that clot busting medication. Okay. A lot of times what we'll see is a patient who went to bed and everything was fine, and then all of a sudden they wake up. So let's say the patient went to bed last night at 11 o'clock, okay? And now all of a sudden this morning, they wake up at 8 o'clock, 7 o'clock, and all of a sudden they notice that they're really weak on the one side, they have blurred vision. They are no longer within that level 1, okay? Because they're over the 4.5 hours. But they meet the level 2 criteria because they are within that 24-hour time frame where they could potentially have an endovascular treatment. Okay, so we still want those patients to get in here as quickly as they can, so they can get imaging done. And again, if it shows a large vessel occlusion, that the interventional neurologist can get in and get that clot out of there within 24 hours. That's what makes them a level 2. Okay, and then finally, our level 3 is we think of these patients as special circumstances. Okay, these are patients that may not receive any treatment acutely because obviously their last known well is greater than 24 hours and then of course greater than 4.5 hours. So they don't qualify for either the alteplase or the endovascular intervention, but they still need treatment, correct? So here at Essentia or at any comprehensive stroke center, a lot of times the EMS system will call the switchboard of the hospital saying, you know, we have this stroke care patient. They'll give them a quick report about last known well, what the symptoms are, and then the switchboard operator will alert the stroke care team, which includes me, the coordinator here, our interventional neurologist, and our NP. And we will all run and meet this patient in the ER, and it's a very quick process once they get here. Okay.
So Molly, so
Yes.
so traumatic brain injury is mostly what we see, and stroke we actually just added to the definition of brain injury in 2017. So fairly new area for us. So when we present and we talk about TBIs, we talk about the severity continuum as far as loss of consciousness. But with stroke, you're saying it's more of the kind of stroke.
Yes.
And so that's done through like imaging. Basically.
Exact symptoms.
Okay.
So deficits. So the big thing when we think about strokes is what deficits are the patients having. And that's really going to tell us the difference between is there an ischemic stroke process going on or a hemorrhagic stroke process going on. With our hemorrhagic stroke process, especially our subacute or excuse me, a subarachnoid hemorrhage, they're going to have loss of consciousness pretty quickly. They're going to have nausea and vomiting. Okay. Where with the ischemic strokes, you see more of this facial droop, more of the sudden weakness in the one side of the body, the slurred speech. Okay. So again, we're looking more at initially like what deficits are going on with this patient. And yes, we need to get them in, get them a CT scan and get them treatment right away. Then we kind of look long-term, what do these deficits, how did that impact of the stroke on the brain tissue? What is that going to result in as far as that brain injury? Okay, and what deficits do the patients now have because of this stroke?
Okay, thank you. Thank you.
Yeah, good question. So when a stroke alert happens, whether it's an inpatient stroke, so let's say a patient is here, maybe they had a knee replacement surgery 2 days ago and they're about ready to go home, okay? Or a patient is again coming from an outside facility and they are on their way because all of a sudden they had stroke symptoms at home. A stroke alert is called here at Essentia or any comprehensive stroke center, and we run. As you can see, this patient in the picture runs. There's a big old team that's about 10, 15 people are in the room at a time with these patients, whether it's the CT person, whether it's lab, whether it's somebody doing an EKG, the nurse in the ER, me as the educator, our coordinator, sometimes interventional neurologist, the ER doctor. There's just a bunch of people getting in and evaluating this patient, okay? So again, confirming that last known well. I can't say that enough. This is going to give us really kind of the roadmap of what kind of treatment this patient can get, okay? Of course, when a stroke alert is called, that makes the doctors put in the order set for the stroke alert, which cascades a bunch of orders, okay? Telemetry, vital signs, stat labs, non-contrast head CT. We do an NIH scale, which we're going to talk about in a little bit. And then there's this question down here. Are they on an anticoagulant? Why do you think that would be important? Does anybody remember?
Because those ones are to prevent clots, right?
Mm-hmm.
So if they're on one, you wouldn't want to give them too much, right?
So so kind of looking at both sides, so our ischemic strokes and our hemorrhagic strokes. So ischemic strokes, if they're on a blood thinner and they're within that 4.5 hours, and we want to give them alteplase, which is a huge clot busting medication, is that probably a good idea? If they just took the new, because what's going to happen? We're probably going to throw them into a big bleed. Okay, so if they're taking Coumadin or they're taking some type of blood thinner, and yes, they're within that 4.5 hours of last known well, and they could potentially receive alteplase, is it really a good idea or not? Okay, and then looking at the hemorrhagic stroke, okay, this patient is on anticoagulation and all of a sudden now they have a subarachnoid hemorrhage or a spontaneous ICH. We need to reverse that anticoagulation quickly, okay? So that's a big question. Are they on an anticoagulant? And when was the last time they took that? Okay. So this is our inpatient process here, is that any patients on the floor that all of a sudden, again, maybe we have a patient who had a knee replacement and all of a sudden the nurse goes in to do her 8 a.m. assessment, is like, something's off with this patient. Like they can't lift their arm up, you know, their speech sounds weird. You obviously will do a stroke alert, and you need to get these door to goal times like quickly. Okay. Now, whether this is inpatient, the patient's already in the hospital, or whether the patient is coming in through EMS or like a life flight. Okay. And we are quick with our times, especially this one. These are the big ones that we, when I talked about the data queen that I work with, she looks at these numbers, and we celebrate when we get these numbers, and we get not upset, but we recognize where we need improvement if we can't quite meet these metrics. Okay. This 30-minute IV alteplase, that's quick. Okay. And then again, 90 minutes from door to endovascular intervention. Time is brain, as you guys I'm sure have heard with lots of things. So just a little bit more about our thrombotic therapy for ischemic stroke. Okay. As you guys all probably know, TPA stands for tissue plasminogen activator. Okay. Also called Activase or alteplase. Okay. So again, what does alteplase do? Why is this such a good medication for giving patients who are having an ischemic stroke? Okay. The mechanism of action of this medication is that it binds to fibrin in the thrombus. So in the blood clots, it binds to that fibrin and converts the entrapped plasminogen to plasmin. Okay, so it thins out that blood, initiating a local fibrinolysis. So breaking up that clot. Okay. One thing, and you guys were probably on the meeting last week for the North Dakota stroke conference thing. Maybe some of you were on that. The big thing coming up the pipeline is tenecteplase. And I know me and my coworkers here really enjoyed that talk and are really anxious to get that going here at Essentia. Sounds like a great thing. So this is still kind of the old school, but it's an effective thing. So alteplase, as of right now, is considered the standard of care for an acute ischemic stroke. What's nice with our alteplase versus tenecteplase is right now alteplase is FDA approved. Okay, this is the FDA's window is getting that patient that alteplase within 3 hours, but for us here as a comprehensive stroke center and other comprehensive stroke centers.
For you guys?
Yep, so we try and give it obviously as soon as possible. The 4.5 is the cutoff for us. Okay. So let's say a patient's coming in, they meet the criteria for getting alteplase. Their last known well is less than the 4.5. We know that alteplase is a medication that's going to help, but we need the interventional neurologist or a doctor to talk to the patient about the risks and benefits of giving the alteplase. Okay. The discussion is a little bit intense because, again, this is a big time clot busting medication, which can ultimately cause significant bleeding in the brain. Okay. So a thorough conversation needs to happen between the interventional neurologist and the patient. Okay. Obviously, if the patient agrees to the risks and benefits, we then have them sign the consent form. Okay. When we talked about exclusion criteria, so a patient meets the criteria for alteplase versus they don't meet the criteria. So these are the key exclusions. So somebody comes in and when they have that initial CT scan, there's white areas that light up. Means that there's an active bleed going on in the brain. We're obviously not going to give a clot busting medication. Okay. That INR is greater than 1.7, meaning that that patient's blood is already very thin and we're not going to give an additional medication that's going to cause bleeding. Okay. Again, beyond the 3-hour time frame window for patients 80 years and older. These are kind of one of those circumstances that, depending on that risks and benefits, what's going to happen. Okay. And then beyond the 4.5-hour time frame window for any patient. Okay, the other big thing we have to be aware of when we are giving a patient alteplase is we need their blood pressure to be controlled. 185 over 110 is kind of before we can even start the alteplase. We want to make sure that that is below that. Okay. There, she's back. Okay. So this is actually a really interesting graph. And sometimes some of the interventional neurologists will actually show this graph to patients because, again, alteplase is a medication that's a high risk medication, a very high risk medication, because it's a clot buster. It's a big time blood thinner. It's going to break up that clot. Okay. So again, the risk of having bleeding can happen. Okay. But if you look at this picture and you see of all the patients, of 100 patients that received alteplase, what happened with these 100 patients? Okay. As you can see, most are these patients up here. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, about 13 of our patients became more normal or nearly normal. So went back to their baseline. Okay. These other patients, the lighter green is that these patients got better. Their deficits or their symptoms got better. Okay. Most of our patients, as you can see with this graph, had no change at all. Okay. Initially again. Okay. And with this, when you think of 100 patients, 2 of 100 patients got worse. Okay. Worse meaning that they potentially bled. Okay. And then of 100 patients, 1 patient who received alteplase wound up severely disabled, possibly because of a brain bleed, or they bled out and died. But if you look at this picture, really ultimately alteplase is a safe medication and is an effective medication in giving to a patient with an acute ischemic stroke. So any questions on that? All right. So again, we already kind of looked at this. The National Institute of Health recommends patient receive alteplase within 60 minutes of arrival to the ED. We are within 30 minutes, so we are at half of that. And I can tell you, like I said, the person who does the data here, we are proud to announce that we have very good door to alteplase times. And again, that's what makes a comprehensive stroke center so good with their stroke care. Okay. So for us, failure to achieve door to drug times in 60 minutes, or in our case, 30 minutes. Well, I don't know. I'll have to ask Trish about that. If it's considered a failure on our part, if we're below or if we're above that 30 minutes. Is it considered a failure if we go or we don't meet our 30 minutes, or is it 60 minutes that's considered a failure? So 60, okay. Unless there's a documented reason. Excellent. See, she just knows all that stuff that I need to know. Okay, so again, this is who we are certified by as the DNV. So again, when they come around and do our survey, they look closely at our core measures. And if they're seeing that we're consistently failing that door to alteplase time, we may not get recertified as a comprehensive stroke center. Okay. So I think that's partially why we set our goals a little higher into that 30-minute category. Okay. So, and just talking a little bit more, so we looked at the alteplase, now looking a little bit into endovascular thrombectomy, which is again something we have, or something that comprehensive stroke centers will have, is these patients with acute ischemic strokes, if they're within 0 to 24 hours of their last known well, okay, depending on what that imaging shows, that, okay, there's a big clot in that middle cerebral artery in our brain, and that clot is causing a large infarction. We need to get in and get that taken care of. These patients will go in and have what's called a thrombectomy. Okay, so this is where our big time interventional neurologists are people, are radiologists that can read these images and like, yep, this is what's happening. I'm not to that point yet. I don't think I'll ever be to that point, but they are able to determine what is happening in that patient's brain based on imaging. Okay. And then there is that term again, looking at, is there penumbra? Okay. And if so, is it getting blood? So if we can get in and get that endovascular thrombectomy completed, are we going to save that penumbra, or that area of tissue in the brain that's destined for infarction if we don't do something? Okay. These are amazing pictures to me. So the picture on the left here, as you can see, here is our nice clot. So here is our one of our major blood vessels or arteries here, and you can see this big clot right here. And as you can see, there's no blood flow to this area of the brain. Okay, not good. Okay. We go in and the doctor decides, yep, I can go in and do a thrombectomy and we can get that clot out of there. Okay. As you can see kind of right here, this lighter thing is this is the device that they use to go in and suck or take that clot out. Okay. After that happens, oh my goodness, look what has happened. Look at that blood flow. So we have now, again, there is an area of infarction in the brain, but we have now restored blood supply and blood flow to these areas of the brain that, in other words, would have died. Okay. This picture to me is amazing. Okay. To see that. This next picture is also amazing to me. To think that this clot was blocking one of the arteries in the brain. And that with this little endovascular device, they were able to take this huge clot out and restore the patient's blood flow to their brain. So I think that's very cool. Any questions on treatment for ischemic strokes? Okay, just really quickly, I want to just kind of review the NIH or the National Institute of Health Stroke Scale. Okay, so when we talked a little bit ago about deficits, Carly had mentioned that, you know, when we think about traumatic brain injury versus kind of what's happening with the stroke, is we look at what is happening with the deficits of a patient. Okay, when we think about our neurology system, what deficits is the patient having? And that can be linked to, okay, where in the brain is that stroke occurring? Okay, when a patient comes in and is a stroke alert, me as an educator or my coordinator that I work with, or the NP or one of our doctors will perform an NIH as soon as they get into the hospital. Okay. This is, as you can see, the severity. Okay. 0, no stroke symptoms. Okay. I will tell you that we have patients that come in that may have stroke symptoms at home, like all of a sudden they had weakness on their one side of their body. Maybe their wife or husband noticed a little bit of facial droop. Okay. But by the time they get to the hospital, that's all better. That again could potentially be a TIA, or it could potentially be that there is a stroke going on, but maybe this patient's symptoms are not as evident as they were when they were at home. Okay. This is the area, the 5 to 15, and actually it's more like a 6, but anytime a patient comes in and we're doing a stroke alert on them and their NIH score is greater than 6, that makes us realize that maybe there's a large vessel occlusion going on, which means that the patient is maybe going to need one of these. Okay. If that patient has an NIH score of greater than 6. That a lot of times we'll tell our doctors, okay, I think there's a large vessel occlusion going on here. Okay. Unfortunately, we do see patients who have had maybe a massive stroke in their sleep come in and their stroke scores are in the 30s and 40s. Okay, those are really unfortunate. And a lot of times those are the subarachnoid hemorrhages. And there's, again, not much we can do at that point, but they still need our care. Okay. So another thing I always like to mention is when we're thinking about our NIH scales, we really associate those with rehabilitation, okay, or rehab. And I know Dr. Kenny last week at our North Dakota Stroke thing came in and talked a lot about rehab, okay. So when a person comes in and has had a stroke, we give them an initial stroke scale score, okay? And then again, after they've had alteplase, after they've had the thrombectomy, after maybe they've had to have a craniotomy, whatever it may be, we do these NIH scales every shift or especially every day to see, are these patients' deficits getting worse or are they getting better? Because that's going to help us predict what kind of long-term treatment is this patient going to need. Okay. And again, with our patients who have the higher scores initially and meeting initially with when they come in for a stroke alert or right after treatment of like alteplase, thrombectomy, their scores may be very high. Okay. And that kind of maybe is associated with that. Okay, this patient is going to probably need some extensive rehab after they're stable enough here in the hospital. Okay. It is amazing though when people come in and they initially have a NIH score of 9, okay, 9 or 10, and then by the time they're done here with their acute phase of their stroke, they're down to like a 1 or 2. And again, that's that interdisciplinary team approach we do here, that PT, OT, speech therapy, okay. The big thing, and this is hard sometimes for me, is those guiding principles, is no coaching, okay? I don't want to, okay, tell me, one of the things is, can you tell me how old you are, okay? And the patients, you know, sometimes you'll have a joker saying, oh, I'm, you know, 29. Well, technically you answered that wrong, and I can't accept that as an answer. So I can't really coach them. So that's the big thing. You can't coach your patients, okay? This is the other big thing. Record what the patient does, not what you think they can do. This is the big one, okay? The most reproducible response is generally their first response, okay? And what's the purpose of the NIH? We're testing for deficits. What is that stroke doing to that patient's neurological system, okay? How much time do we have, Carly?
You still got about 40 minutes if you'd like it. You have till 3.
Okay,
if you want.
perfect.
Yeah.
Any questions so far, guys? Okay.
I have questions too. If you want to type in chat, I can read your questions if you'd rather do it that way too. If you come up with any, but or you can unmute and talk.
Yeah, I don't bite. So again, looking at our NIH, so let's break it down here. So the first one is that level of consciousness. So is that patient alert? Are they talking to us? Are they moving? That kind of stuff. If they are, then we give them a 0, that everything, you know, they're alert, they're good, okay? But maybe you have a patient who's pretty sleepy, but is easily too aroused to voice and touch, okay? We give them a 2. Again, the worse, the higher the number, the worse the score, right? We just talked about that, okay? Number 2 is they just can't stay awake. Like you constantly have to wake them up or constantly have to say, hey, you know, Molly, wake up, okay? 3 level is when they're pretty much you can't wake them up, okay? They're unconscious, okay? So again, the higher the score, the worse the deficit. Another part with our NIH, so 1B, is those questions. The 2 questions we ask our patient is, okay, I want you to close your eyes nice and tight for me, and then I want you to open them up, okay? Are they able to do that, okay? The other question, oh, excuse me, I said that wrong. Go back, delete, delete, delete. Questions. I was thinking ahead to commands. Okay, questions is, can you tell me how old you are? Okay, I'm 36. So I would come in and say, if somebody asked me, Molly, tell me how old you are. And I was to say, I'm 28. I would be wrong, okay? And they would score me as 1 incorrect, okay? The other question we ask the patient is, what month is it? Okay, so again, what month is it? And I was to say, oh, February. Nope, it's December, okay? I would get a higher score because I didn't answer either of those questions correct, okay? So again, no coaching. So let's say the patient says, oh, I'm in my 70s. Well, how old are you? You have to get that direct response, not, oh, I'm in my 70s. Nope, you get 1 wrong on that because you didn't say I'm 74, okay? Then the commands. So this is when, okay, Molly, I want you to close your eyes nice and tight and open them up. Can I do that? Can I understand that command and do that? The other command is we ask them, okay, I want you to make a fist with your hand, okay? Can they make a fist? And then open it up, okay? If they can't, then they score that they can't do it, okay? LOC, level of consciousness, is a key indicator of our outcomes, okay? That's it's pretty straightforward. If you have somebody who comes in, they're unconscious, there's just no response to them, means that there's probably a major stroke has already occurred in their brain, or a stroke is happening right now and it's causing significant damage, okay? Especially when we have our strokes that affect our cerebellum, okay? And that's that pretty much our lifeline is that cerebellum. It controls blood pressure, controls breathing, all of that, okay? And I will say that we've had patients who come in with that. Okay, lateral gaze. So this is the second area we look at when we're doing our NIH scale. So I hold a finger up. Obviously, if the patient has glasses, we have them put their glasses on. But we say, okay, I want you to look at my finger and I want you to follow my finger side to side with just your eyes. Sometimes patients will like to move their head and we say, nope, hold your head still. I want you to follow my finger with just your eyes, okay? We're checking for lateral gaze, okay? So we go from side to side. And are their eyes moving with my finger, okay? If they have normal side to side movement, that's excellent. They score a 0. Partial side to side movement, meaning that let's say I'm having a stroke on the right side of my brain, okay? I will look to the right side of when they do the lateral gaze, I will look to the side of my stroke, so in my head, but I will not look to the other side, okay? And then higher score is when their eyes are just fixed and they can't move at all, okay? It's just fixed vision, okay? So for our patients that are, when we're thinking about our lateral gaze, okay, our aphasic patient tips, walk around the bed and watch for eye movements, okay? I don't know if any of you have heard of this. Another word for this is our doll's eyes, okay? And that's when, and one of my colleague, the coordinator who does the NIHs with me is very good at this. And this is something that you use. So again, if they can't follow side to side, what you do is the doll's eyes response, which means you're almost darting your hands towards their eye. And does their eye flinch with that movement? So again, if you think about you're taking and you're almost looks like you're going to poke them in the eye, but they respond, that's a good thing, okay? But unfortunately, we have patients who, when you do the doll's eye test, they don't flinch, okay? Their eyes don't flinch, okay? Comatose patient tips, okay? Again, we just talked about the doll's eyes, okay? My phone is ringing, leave me alone, people. Okay, next on our NIH is our visual fields, okay? This is when we have the patient, if they can, we have them cover up first their left eye, and we, on this eye, then again, we have them look straight ahead, and we hold up the number in the different visual fields. So what number am I holding up here? And again, they're looking straight ahead. Can you tell me how many numbers I'm holding? 1. Can you tell me how many numbers I'm holding? 3, okay? And we're checking to see what their visual field is like. Another thing we do at that same time is we wiggle our fingers. Can you see me wiggling my fingers up here? Can you see me wiggling my fingers down here? Can you see my fingers over here? Okay. Then we have them take and sometimes, again, if that patient has complete weakness on the one side, they obviously can't put their hand up and cover their eye. So then you need to do that. Okay. That one's pretty straightforward. Any questions on that one? All right, facial palsy. This one can kind of be tricky a little bit. Because sometimes people just don't want to smile. So we say, can you give me a big smile, or can you show me your teeth? You know, and some people just nothing. And it's like, I need to see your big smile, or show me your teeth, you know, and some people just don't do that. So then if I kind of notice, okay, they're not wanting to do that, I'll say, well, stick your tongue out at me. Okay, they'll stick their tongue out at me, and the tongue will deviate towards the side that they're having issues with. So again, they're having a right-sided stroke, the tongue will deviate to the left, okay? And I've had patients stick their tongue out at me, it's okay. Okay, the other thing is that when our patients, if they actually do smile, you can definitely see that facial droop pretty significantly. And sometimes you don't even need them to attempt to smile because you can see the significant facial droop. The other thing we have them do is after they smile at us, we have them raise their eyebrows, okay? And is there drooping to that eyebrow, okay? And that's pretty significant if they have both a drooping on their lip and a drooping on the eyebrow, so that whole side of their face is drooping. Okay, that's pretty significant. So again, they score a higher score with that if they're both their eyebrow and their lower face is weak and it's drooping. Okay. This one can be a little tricky, and I've had, when I first started in this position, I was kind of showed one way to do it. I've seen certain people do it another way, but in doing the hemisphere videos as part of our yearly education is our arm weakness score. Okay. Do it one at a time, so one arm at a time, and we actually have the patients close their eyes, and we have them do one arm at a time. We have them stick it out like this. A lot of times people will say stick your arm out and have it palm up, but if you think about that lateral rotation in your arm, it's easier to hold your arm up like this than to turn it like this. Okay, so what we have the patients do is stick your left arm out, and I want you to close your eyes and hold your arm up for 10 seconds, and you count down or you count to 10. Okay, so 1, 2, 3, 4. Okay, why do you think we have the patients close their eye when we're checking for arm weakness? Why do you think we have them close their eyes? Nope.
You're looking at like balance too, if they're, or are they standing when they're doing it?
Close. Nope, they're laying. They can be
Okay.
standing, but most of the time they're laying in the bed. It's because if somebody tells me to stick my hand out and all of a sudden I see my arm is drifting, what's my first response going to be?
Oh,
my arm's
sure.
drifting.
Okay.
My arm's drifting. So they're going to try and trick you like, oh no, my arm's not drifting. Okay, nope. That's why we have them close their eyes, because they can't really tell or can't see when their arm is drifting. Okay, so then again, we do it on the same, we have them do the left side and then we have them do the right side. Okay, no drift means they're able to hold their arm out 90 degrees or 45 degrees if they're laying in bed. Okay, and it doesn't drift at all, they get a 0. Okay, if all of a sudden they're drifting, but it does not hit the bed, they still get a score of a 1 because their arm does drift, but it does not hit the bed. Okay, a 2 is when a patient is holding their arm out and it drifts down, 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 and within that 10 seconds, it hits the bed. Okay, and now as you can see, the higher we get, the bigger the deficit. So all of a sudden I say, okay, I'm going to hold your arm up here and I'm going to let it go. And I want you to hold your arm up for 10 seconds. And I let go of their arm and it instantly drops. Okay. That means they get a 3. That means they can move it, but they can't lift it. It hits the bed right away and there's nothing there. Okay. 4 is when there's no movement at all. Okay. Untestable is another thing that sometimes we will score these patients as. Let's say they've had an amputation. This is more so with our legs, but we do see amputations of the arms. Okay, or if they've had a joint fusion. Okay, that's really hard in some cases when you have a stroke alert and you have this patient who is a level 1 stroke alert. We know time is brain. We need to get that patient done. Are we going to have time to look into the patient's chart to see if they've had a joint fusion surgery? Probably not. Okay, so but kind of think about, okay, well maybe they do have that. Okay, and again, the biggest thing is to count out loud so that patient can hear you. Okay, so okay, Molly, I'm going to hold your arm up and I want you to hold it up there for 10 seconds, and as soon as you let go, you count out loud on both sides. Okay, leg weakness. So again, patients either laying down in bed or sitting up. Okay, same thing, we test the left side and the right side. Sometimes I will have the patients close their eyes on this. You don't necessarily need to, but again, if they all of a sudden put their leg way up and their leg starts to drift down, what's our natural response? Oh, I got to get my leg back up there. Okay. When a patient has significant weakness or is unable to move their legs, a lot of times what I've seen our NPs do is where they'll go and press on the heel or press on take their fingers and run their fingers along the base of the foot. And does the patient flinch or does the patient move? Okay, that means that patient can still move that leg, although they can't lift it. Okay, and then no movement is when that patient can't lift it, and when they do that heel stroke, when the doctor does the heel stroke, there's no reaction. Okay, again, the higher the number, the bigger the deficit. Okay, and then again, untestable, again, joint fusion and amputation. The only difference between the legs and the arms is that with the legs, we have them only hold it up for 5 seconds. And I will tell you, some patients struggle with that. And so when we lift the leg up and we say, okay, this might be hard, but I need you to hold your leg up for 5 seconds. And again, you count 1, 2, 3, 4, 5. Okay. Any questions so far on leg weakness, arm weakness? Okay, this is kind of an interesting one, is coordination. Okay, or what we call ataxia. This might be a little tricky, especially when we know we've just done, let's say, the arm weakness and the leg weakness, and we know that that patient is completely out or extremely deficit on their right arm. Okay, we still need to test the coordination in that arm. Okay, so let's say again, okay, I want you to try and lift your hand here, and I want you to take your pinky finger and touch my finger and then touch your nose. Obviously, if they can't lift that arm up and make a pointer, they're going to score bad again on this coordination as well. Okay, but again, we all have patients who there's no issues with weakness, but they have issues with coordination. So as the tester, I say, okay, Molly, I want you to, you see my finger here? I want you to take your pointer finger on your left hand, and I want you to touch my finger and touch your nose. Okay, and then I move my finger, touch my finger, touch your nose. Patients who have coordination issues will, let's say, I don't know if you guys can see this, but all of a sudden they can't touch my finger right, or they go way over here, or they fall short. They are not coordinated enough to take their finger and touch my finger, or they're not coordinated. They can maybe touch my finger, but they can't come back and touch their nose. Maybe they touch their cheek. Maybe they touch their forehead. Okay. That means they're not coordinated on that upper extremity, that left upper extremity. You then go over and do it on the right side. Okay. So those are our upper extremities when we're thinking about coordination. But we also need to think about coordination, just like we looked at weakness with the upper and lower extremities. We need to look at coordination of the upper and lower extremities. So with our lower extremities, we do what's called the heel to shin test. And sometimes patients may need a little help with this. So let's just pretend this is my leg, okay? And this is my other leg, okay? I'm gonna bring my person's leg up to here, okay? And then I tell them, okay, I want you to run your heel, the heel of your one foot of the opposite leg down your shin and run it back up, down and up. And we have them do that a few times. People who have issues with coordination or ataxia can maybe do it once, but then it falls off, okay? Or they cannot do that movement up or down. Maybe they can just go up, but they can't go back down. Or maybe again, it falls off, okay? This one gets to be a little tricky because we score coordination only if it's caused by weakness. Excuse me, score only if not caused by weakness, okay? Which means when we have our patients that come in, or maybe, you know, older patients, 80s, 90s, they're probably initially already a little bit weak, okay? So can we technically score a patient who already has known weakness, but we think they're having a stroke? So is this coordination issue caused by the actual stroke going on, or is it they're not coordinated enough to run their heel up and down their leg because they're too weak? If looking at the patient and saying, okay, yep, this is probably more related to their weakness, not probably related to their coordination, then we score them obviously UN, untestable, okay? This gets to be a little tricky, and it just, again, takes practice. Okay, any questions? Okay, sensation and neglect kind of go together. So our number 8 and our number 11, and we'll get to number 11 here, but sensation, okay? This is when, and again, I've seen this done differently. I've seen it where people just take their fingers and touch the patients. Here at Essentia, my partner and I, we actually have those Q-tips, those long Q-tips that have both the blunt end and then the sharper end, okay? And what you do is you take the 2 Q-tips, you start at the face, you have the patient close their eyes again, because again, you're going to be asking the patient, you know, what side am I touching, or does this side feel different than the other side? And if you have the patient open their eyes and they're touching them with the sharp end on one side and the dull end on the other, they can see that, okay? So again, we have them close their eyes and we say, okay, what side am I touching you on? Okay, you alternate touching them, Okay, touch them on the one side, touch them on the other side, touch them on both sides. Okay, and then we take again, does this feel different? Does this softer end feel different than this? We don't tell them that, but we say, does this feel the same as this? And on one side, we may be touching with the cotton tip of the thing. The other one is the end. And if they can't distinguish the difference between sharp and dull, there's a sensation issue. And we work all the way down the body. So we start at the cheeks, we then go to the arms, and then we go to the legs. Okay. So again, touch both sides of patient's face, arm, and legs. And you ask them, does this feel the same on both sides, or is it different on one side? Okay. Any questions on that one? That one's kind of a fun one to do. Just don't poke your patient too much with that Q-tip. Okay. Everybody doing good? All right. This is the one that I tend to like when I remember the picture. Yesterday we had a stroke alert and I forgot to bring my little picture with. But speech, this is a big thing to test when we're looking at deficits. Obviously, with our big strokes or the stroke set cause a lot of deficits. Patients can develop expressive and receptive aphasia. And this is when this happens, it's pretty significant. But how do we test this? So we are it's kind of two parts. So the first part here at number 9 is comprehensive or comprehension. Okay. We have these pictures. And these are part of our stroke alert packs. We have these 2 pictures. So we hold up the picture in front of the patient and make sure they have glasses. You say, oh, I'm going to get you your glasses and I want you to tell me what's going on in this picture. So you hold up this first picture and we ask the patient, what's going on in this picture? Tell me what's happening. Okay. Patients a lot of times will say, oh, looks like the mom's washing some dishes and there's some water flowing out of the sink. And then there's a boy on the stool that's going to fall over, but he's trying to get a cookie. Okay, they can comprehend what's going on in that picture. But thinking back to when a patient has sensory deficits with their vision, okay, all of a sudden we know that maybe they can't see very well on the left side. So when I'm holding up this picture, all that patient can see is the lady washing dishes. They cannot see the little boy and the little girl trying to get cookies. So they can comprehend what's going on one side of the picture, but not on the other. Okay, so we would score them a little bit higher if they cannot see the entire picture. Okay, we then flip the card over and we point to these objects. And we point to these objects one at a time and we say, okay, Molly, can you tell me what this is? Okay, this is a glove. Okay, sometimes people will say hand or mitten. That's okay. Then we point to the next one, obviously, which is a key. Sometimes with this one, it's a chair, but sometimes people will say seat, and that's okay. This one is a little bit interesting because sometimes people will say tree, and technically these are trees. But what we're looking for is hammock. Okay, but sometimes people just say, oh, it's a tree or a swing. Okay, feather. And then what's other than cactus? What do you guys maybe see in this picture that maybe we would accept as an answer when we're looking at these cactuses? What do you guys think that might look like? I'll give you a hint, it's an animal.
Yeah, the one on the left kind of looks like a duck to me. Like, no, duck? No.
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 No. Anybody else? How about a squirrel? Some people think they look like little squirrels. I don't see it, but
maybe.
Some people
I guess
say
like a bushy tail. Yeah, I suppose.
Yep. So we actually accept that answer of squirrels. So cactus is actually the correct term, but we do accept squirrels. Okay. So what are we testing when we're looking at this comprehension? Can the patient understand what's going on in the picture? And can the patient name the items? Okay. If you don't have this available at your bedside, that's okay, because then what you would do is almost all of us have a pen in our pocket, we have a watch, or we may have glasses. We point to these objects and say, okay, tell me what this is. Can they tell me that this is a pen? I point to my watch. Can you tell me what this is? Okay, well, that's a watch. Okay, and then I point to my glasses. Can you tell me what these are? Okay, so if you don't actively have this available, you can still test this. You would just need to hold out some common items. Okay. So again, we're looking at speech with both this one, number 9, and number 10. So I'm going to come back and talk a little bit about the difference between expressive and receptive. Okay. In addition, we also have with our stroke alert packets, we have a document. And I don't think I have one available right quick in my hand. But anyway, on our thing, we have these sentences and we tell the patient, okay, I want you to read these sentences to me. Okay. You know how, down to earth, I got home from work, near the table in the dining room. They heard him speak on the radio last night. And, or you can have them read these words. Okay. If you don't have this stroke alert packet available, the term or the sentence we have the patient say is, you can't teach an old dog new tricks. Okay, so if you don't have your stroke alert little packets available, you still need to see, are they slurring their words? Okay, so you say, okay, Molly, I want you to repeat this sentence after me. You can't teach you can't teach an old dog new tricks. And as they're saying that back to you, you can, especially if a patient is having significant slurring, you can hear it. Okay. So again, slurs, but you can understand. Okay. You can pick out some of those words that they're saying. Slurs, but you can't understand. So it's just all jumbled. It doesn't sound like anything. Okay. That's a higher score of 2. And then of course there's the untestable. Again, if the patient scores a 3 on our level of consciousness, they're unconscious. Obviously they're not going to be talking to us. Okay. So untestable means they're intubated or another physical barrier. Okay. So again, what are we really listening for is that slurring of speech. And so when we think about this, we have expressive and receptive aphasia. And this all depends on possibly where the area of the brain where they're having their stroke. Okay. Expressive aphasia is seen in patients who have a stroke in the Broca's area of the brain. Okay. Broca's area, or our motor speech area. Okay. That's located in the frontal lobe of our brain. Okay. Patients with expressive aphasia have difficulty with speaking, writing, and finding words. Okay. What's frustrating with this for patients and for family members is that these patients can speak. They just can't sometimes find the words. Sometimes their speech is significantly slurred. So maybe the nurse or the caregiver or the family member saying, what are you saying? What are you saying? Say that again. Say that again. Say that again. They get frustrated, easily frustrated, because they know what they want to say. They just can't get those words out. Okay. Opposite of that is receptive aphasia. And this is when the stroke affects the Wernicke's area or our sensory speech area. Okay, this is located in our parietal and temporal lobes. So again, the parietal lobe, so our frontal lobe's here, parietal lobe is the next area, and then our temporal lobes go along the side by our ears. Okay, when this happens, patients are unable to understand language, whether it's written or spoken. Okay, patients with this type of injury are unaware of the problem. And this is when somebody just might ramble on and on and on and make no sense. Okay. Maybe you ask the patient, oh, are you having any pain today? And they start talking about the weather. Okay. They don't understand. They cannot receive what you are asking them. Okay. So think about that when we're caring for these type of stroke patients. Can the patient expressively tell me what's going on or not? Okay. Or can the patient understand what I'm saying to them? So can they receive the data? Okay, this obviously can be very frustrating for the patients and the family members. One of the presentations I do, or I'm going to be doing coming up, is for our long-term care facilities that care for patients that may have these, and how we can care for these type of patients, because again, it takes a lot out of the caregiver and the patient if the person you're caring for you doesn't understand you, or if you can't understand the patient. Okay. And then finally, neglect. Neglect goes kind of along with our sensation. Okay. It also kind of goes hand in hand with our vision. Okay, and I should put a picture up here. I know last week when Kathy Lonsky talked on our speech thing, she had a really good picture about a patient's lap, and she had a patient of the patient's the legs, the upper portion of the legs. And patients who have problems with neglect is they can see this side, but they have no idea what's right here. Okay, so all of a sudden you're touching this part of their leg and you say, well, whose leg is this? And they don't recognize that there's anything there. Okay, so this kind of goes again with that sensation. Okay, does the patient ignore one side of the body? That's the biggest thing. Okay, that is the NIH scale. The biggest thing with these patients, especially our hemorrhagic stroke patients, especially our subarachnoid hemorrhages, these NIH scales are extremely important actually for any type of stroke patient, but especially our subarachnoid hemorrhage patients, because stuff can change quickly with those hemorrhagic patients. All of a sudden there's more bleeding in the brain. Maybe there's an addition area of another stroke that's being developed. So if what we tell the nurses caring for these patients on the floor is don't ever copy what somebody else has done the previous shift. One story I'll quickly tell you guys is there was a patient when I taught clinicals for a group of students. We had a patient that was here for probably 3 months. And every day, nothing changed with this patient. We were waiting on placement. And so, but we still had to do the NIH scale daily on this patient. And so every day we kept getting the same score on this patient. And a nurse who had taken care of this patient multiple times decided not to actually go in and do the NIH scale on nights and just copied it from the previous day. The next morning, when they came in to assess the patient, the day shift nurse, the patient had significantly changed, like really bad, like extreme deficits, like worse than they were before. And the other nurse was like, what is happening here? Like this last NIH said it was like a 3 and I'm getting like a 15. Like what is happening here? So obviously they call a stroke alert, get this patient down imaging. During the night, the patient had a secondary massive stroke. And the patient went from being able to possibly be discharged soon to having to be in the hospital another 3 months. So my advice for nurses is to never ever do that. Is when the NIH is ordered as scheduled, you go in and you do your NIH. Yes, it's kind of tedious at times, especially if you've taken care of the same patient for, multiple shifts. You still need to go in and take that NIH, because a significant or just a small change can significantly change the outcome for that patient. So that's my advice with that. Any questions? And this is the team I work with that I mentioned throughout my presentation.
So when you were talking about like the penumbra and like the dead tissue thing, talk to me about like neuroplasticity. How does that, like, does that mean it goes around the tissue? It goes through it? Like what is, I don't.
Very good question. So I'm sure you guys have probably heard about contralateral circulation. So when a person is having a stroke, an acute stroke, obviously, and there's an area of infarction, our brain is amazing in the sense that it is going to go around that and still supply the rest of the brain with blood as much as it can. Okay. When you're talking about neuroplasticity, and I know last week at the North Dakota Stroke Conference, Dr. Kenny talked a little bit about this, and that neuroplasticity is really important for patients in their recovery and we've had patients in our stroke support group say, how am I ever going to get back to the same way I was before? And sad news is you probably aren't ever going to be the same 100% like you were before. But there's stuff that you can do, repetitive exercises that you can do. So if you want to learn, you have significant, maybe slurred speech, and you just can't get over the fact that you have this slurred speech problem. That can get better through repetitive speech pathology exercises. Just like you want your weakness in your left hand to get better, neuroplasticity is stimulated by those repetitive exercises. So whether it's with PT, whether it's OT, whether it's speech pathology, the more you do those repetitive exercises, you're going to be able to stimulate neuroplasticity in your brain, and you are going to make that problem get better. Is it ever going to be, or that deficit better? Is it ever going to be the same like it was before? Probably not, but it is going to get better for what it was before. Does that make sense?
It does. And yeah, we had a speaker on not that long ago that talked about a speech pathologist that had recorded his first session and then played it back for him at his last session. And I just love that idea of showing the growth and because I think people do get very discouraged and frustrated, and will I ever be, you know, back to where I was before. And I think that was a great example. So I think we're going to start trying to do that more that we can, and you know, when we can, try to record people and try to play it back later for them and stuff. But
and I think it's amazing. I used to, before this position, I was an educator at NDSCS, and we had students who went to Sanford Rehab and were able to take care of patients who were just admitted to rehab and patients who were there for months, 3 months. And then at the end of our rotation there, it was amazing to see that, oh my gosh, the patient we just admitted 3 months ago, and my student had this patient the first day we were here for clinicals, and now it's our last day of clinicals, and it's 3 months later, and this patient is like almost like a new person because of their strength that they've gotten back. Their ability to swallow has gotten better. Their speech has gotten better. Their mood has gotten better. It's amazing to see what rehab can do for these patients. And it's important for patients to remember too, that even though you've reached the end of your time at rehab, the physical therapist and occupational therapist will give you exercises that you can do at home that will continue to help stimulate that neuroplasticity. Because I believe it was Dr. Kenny who said that neuroplasticity can actually continue to develop or get better within a year of the stroke.
Okay.
So it's really important that even though, oh, I'm done with my rehab, I guess I don't have to do these exercises anymore. Again, you put what you put into it is what you're going to get out of it.
Thank you for explaining that. That's great. Yeah.
So.
And then you did mention discharge at one point, and I know that's always kind of something where do you guys usually at home? Are you seeing most people go home or rehab or what?
So again, that all, when we think about our NIH scales, obviously these patients who have the severe, that's why NIH is initially when we do those stroke alerts, and then maybe after they've had their thrombectomy. But again, there's certain things when and that's why our case management team here at Essentia is wonderful to kind of see how is this patient progressing, and will they be safe enough to go home?
Sure.
Do they have family members who are willing to help them go home?
Yes.
Or is the patient, single and has no support? Okay, maybe it's going to be safer to send this patient to a rehab facility for maybe a few months and then talk about potentially sending them home. So that's what's different with every stroke patient. That's why I find stroke care so interesting, is that you can have 100 patients who have all had a right posterior stroke. And every single one of those patients are going to present differently and are going to progress differently. And that's why stroke is so interesting, because again, it's after it's happened, what are you going to do as a patient? It's kind of almost, I watched a presentation once about rose-colored glasses. Okay, this is the worst thing that's ever happened to me. And what am I going to do about it? Am I going to look through rose-colored glasses, or am I going to not?
Thank you for, yes, I forgot about that slide that you did talk about that. We just have trouble finding like long-term facilities for people.
Yes, that's so
Nikki's role is resource facilitation. So she gets called all the time about, where can we go next? And North Dakota we don't have.
And we have, we've had patients who will be in the hospital here at Essentia, and they'll be doing excellent, and they're in the hospital for 6 months. 3 of the months they probably didn't need to be in the hospital, but it's because they had nowhere to send these patients.
Right.
So that definitely gets to be tricky, and I can only imagine what the case managers have to deal with that. So.
Right. Well, that was awesome, Molly. I would never guess you just started. You did amazing. Seriously, you did great. And I texted Nikki, I was like, this girl's great. Like, you just explain things in a very, easy to understand way. And you did a great job. So
thank you.
Thank you so much.
Any other questions?
Yeah,
I'm glad somebody asked questions.
I kind of took over this time, but anybody else have questions or comments for Molly? Josie says, thank you for the informed presentation.
Thank you.
All right, well, if you
Thank
think
you
of
guys for your
questions later,
time.
you know how to get a hold of me, so you can always ask me and I can ask Molly.
Yeah.
All right, so nice to meet you and thank you for your time today.
Yes,
And-
thank you, everyone.
Okay, have a
Take
good
care.
one. Bye.
Bye.